Well, welcome everyone. We are delighted to have an amazing group of people to help us reflect on examples and priorities from health systems, academia, and funder perspectives on bridging the gap in implementation science. Next slide. So I am moderating. I'm Rachel Sturke. I'm the Deputy Director of the Center for Global Health Studies at the Fogarty International Center at the U.S. National Institutes of Health. And I'm co-moderating with Sherr, who is Professor of Global Health at the University of Washington and the Director of their Implementation Science program. And the session overview, so the plenary is really intended to center on the role of implementation science, really to foster scale-up of evidence-based interventions to achieve population health improvements in low and middle income countries. And this is sort of a priority that we've been hearing from multiple stakeholders in low and middle income countries. And really we'll begin by describing the motivation for implementation science and define the central principles, just to give a little bit of an overview of what we mean when we say implementation science. And then we've asked our panelists to give perspectives from their respective areas on examples of how implementation science has informed scale-up of evidence-based interventions, and then really priorities for implementation science to foster scale-up. We've sort of binned our panelists into different sections, although many of them wear multiple hats, so probably could speak to multiple perspectives, but we're looking to inform the discussion by a perspective from academia, a perspective from sort of policymaker ministries of health, and a perspective from funders. And we hope to follow this by moderated discussion and welcome your questions. I think in the chat is the easiest way to receive them. Next slide. So our first panel is the Ministry of Health perspective, and we have Dr. Patty Garcia, who is Professor of Public Health and a former at the University of Cayetano in Peru, and the former Minister of Health in Peru. We also have Dr. Peter Cherutich, who is a Senior Deputy Director of Medical Services in the Ministry of Health in Kenya. So two really rich perspectives. Next slide. Panel 2 is intended to capture the academic implementation researcher perspectives. We have Agnes Binagwaho, who is the Vice Chancellor and co-founder of the University of Global Health Equity in Rwanda. We have Malabika Sarker, who is Professor and Acting Dean of the School of Public Health at University of Bangladesh. And we have Roman Shu, who is Professor of Public Health and Director of the CUGH Labs at the Southern Medical University in China. Next slide. And panel 3 is intended to capture the funders' perspective. And so we have Anita Zaidi, who is President for Gender Equality and Director of the Vaccine and Development and Surveillance, and Director of Enteric and Diarrheal Diseases at the Gates Foundation. We have John Reeder, who is the Director of TDR at the World Health Organization. We have David Chambers, who is Program Director for, Deputy Director for Implementation Science at the National Cancer Institute at the U.S. National Institutes of Health. And then we have Lola, I'm gonna butcher your name, so I'm not gonna say it, who is Program Director for Child Wellbeing and Director of the African Health Initiative at the Doris Duke Charitable Foundation. Next slide. So I'm just gonna hand it over to Kenny, but just to say thank you to all of our panelists for offering their time and their wisdom to us. I think it'll be a really rich discussion and session. Over to you, Kenny.
Great, well, thank you, Rachel. And I'll also extend my gratitude towards the panelists and the CUGH for hosting this panel today. And also complete Lola's introductions, Lola Adedokun, who's now at the Institute, a longtime colleague and a supporter of implementation research. So I think in the field of global health, as well as in high-income countries, so low and middle-income countries and high-income countries, we have a fairly consistent no-do gap, or this gap between what we know works from evidence-based or evidence efficacy trials, excuse me, early in the morning here in Seattle, but yet the application of these evidence-based interventions lags in terms of time and reaching scale. And as a result, we have an unaddressed disease burden that we can start to address through putting into better use or better deploying this large list of evidence-based interventions that we have at our disposal, which has really grown over the past 20 years with larger increased investments in the global health arena. And I'd like to start today by making a distinction between implementation and implementation research or implementation science. I often speak with people who are working in the implementation space, and they will say that rightly so, they're working partially in implementation science. But I think there's, as the field of implementation science or research has grown over the past 15 years, there's really been a large set of tools and approaches and concepts that have come to the fore that are really can be applied to try and close this no-do gap, to try and get more scientific in how we understand implementation and deploy interventions and put into place strategies that increase the routine use with quality of evidence-based interventions to address some of the pressing global health issues that we face. So implementation is an intentional process. It's to purposefully or intentionally put evidence-based interventions into practice or use. It's what we do day to day, largely through investments, through health systems, and through major donors, through governments, through multinational initiatives. Implementation research, I'm going to use here the definition from the National Institutes of Health in their program announcement for implementation research, is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and benefit population health. So a few things I really want to call out here. One is it's a scientific study. We really are applying scientific approaches and the scientific method to gather generalizable knowledge to then feed back into improving implementation. And we're focusing on the use of strategies, and strategies being a set of approaches that can facilitate the then implementation outcomes, the adoption, implementation, and maintenance of those evidence-based health interventions into clinical and community settings, with the intent of then improving how systems operate and then improving individual outcomes, and then ultimately at a population level. Next slide, please. So Nola Proctor, who is one of the thought leaders in the field of implementation science, in 2008 published a schematic which helps us kind of figure out how we can organize this flow from interventions, evidence-based interventions or practices, to improving client, and then I would add on to that population level health outcomes. As I mentioned, implementation strategies are approaches that we can use to facilitate the feasibility, fidelity, penetration, acceptability, sustainment, uptake, and costs of evidence-based interventions, also known as implementation outcomes. Those implementation strategies function at multiple levels, at systems levels, at organizational levels, at provider levels, community levels, and can include a broad range of activities, but again, with the intent of facilitating the routine implementation of those evidence-based interventions that will then lead to improved service delivery and then improved patient outcomes. And implementation research methods are applied across this entire continuum. Next slide, please. And we can look to the literature and also to the field for a bit more on what we mean by implementation strategies. I want to make a distinction here between the evidence-based intervention, what has been deemed the 7 Ps, or the programs, practices, principles, procedures, products, pills, and policies that we know work to improve health behaviors, health outcomes, or health-related environments. This is the what we are trying to deliver. And I want to make a note here that we're not just talking about pills or products. We're talking about policies, we're talking about programs, and we're talking about those evidence-based interventions that don't just directly lead to improved health at an individual level, reduced symptoms or reduction of disease, We also include in this definition health behaviors and improving environments that are important for shaping those health outcomes. Implementation strategies, on the other hand, are those actions that help enhance the adoption, implementation, sustainment of evidence-based interventions. They're the how we are trying to implement the evidence-based interventions. Next slide, please. In the field of implementation science has been really actively working to develop the evidence base around implementation strategies. First, by enumerating them, and you can look at the work by Byron Powell and colleagues where they've enumerated 73 discrete implementation strategies, and then studying how they work in different settings and how and why they work or don't work in those settings. Much of the work of implementation science is focusing on testing implementation strategies and the mechanisms of their action, looking at how intensity of implementation shapes the outcomes related to implementation strategies, and how context modifies its impact of strategies in different environments. And also thinking mechanistically, putting these strategies together with determinants of implementation, or those barriers and facilitators that shape how well an intervention is delivered in specific contexts, can help us to understand and apply implementation strategies in a way to maximize their potential benefit. This is an area of formal inquiry, and I think creates a distinction between implementation and implementation science, which is studying how and then deploying strategies in the most effective way. Let's go to the next slide, please. A cornerstone of the field of implementation science is theories, models, and frameworks. We have a lot of them in our field. We can look to work from Nielsen and colleagues to where they've tried to categorize implementation science theories, models, and frameworks based on their intent for use. So the first are process models, and these are models that guide translating research into practice. You may have heard of the EPIS model, or the Dynamic Sustainability Framework, or the PRISM models, and these are models that help as you're trying to take research and deploy them into novel settings to understand what are going to be the potential determinants, barriers, facilitators to implementation, and to plan for to maximize their success. We have a second group of theories, models, and frameworks that focus on understanding or explaining what influences implementation outcomes. And this includes determinant frameworks like the Consolidated Framework for Implementation Research, classic theories like diffusion of innovation theory, and implementation theories like organizational readiness to implement change, which help us as researchers and implementers to understand the how and the why we are seeing the results that we're seeing for implementation in varied settings. And then a final set of frameworks for the focus on guiding evaluation efforts. These include like the RE-AIM framework or other frameworks that help to really to design and deploy evaluation efforts. Next slide, please. And a penultimate slide just mentioning that there are a slew of research designs that we use, or evaluation designs that we use in implementation research that really are positioned based on the intent and the timing of implementation. So if in a pre-implementation phase, we may be looking at acceptability and appropriateness of implementation strategies, while through to late implementation, we'll be looking more at issues around effectiveness and sustained effectiveness of interventions. And I think one of the distinctions between implementation and implementation research is really embedding these designs in a way that to surface learnings related to implementation of evidence-based interventions that can then be fed back into program design in a way that can maximize investments in the implementation and scale up of evidence-based interventions. So final slide. How it all comes together. Effectiveness research, we're looking at whether the evidence-based intervention works. Implementation research, we're studying how to best help people and places do that thing to implement that evidence-based intervention. Implementation strategies are the things that we do, or the stuff we do to try and help people and places do the evidence-based intervention or the thing. And implementation outcomes is a measurement of how much and how well they do the thing, that evidence-based intervention. So I'd like to stop the slide share at this point. I'm going to turn it back over to you, Rachel. Thank you.
Thanks, Kenny. So we're going to start the next session, which is perspectives from the policymakers or ministries of health, where we have Patty Garcia and Peter Cherutich. So I will start with Peter. Is that the order we decided? I think it is. So each of you has a few minutes to make remarks on your perspectives.
Yeah, so thank you very much, Rachel, and thank you, Kenny, for the invitation, and also thank you, the CUGH fraternity, for the opportunity to share a few thoughts on how we can be able to close the no-do gap using implementation science. So just briefly going to talk about how some of my experience I have in terms of how implementation science methods have been or designs have been applied to be able to inform policy, and then maybe briefly just outline one or two priorities that I think are important moving forward. So approaching it from what Kenny mentioned in terms of the designs, and again coming from the field of HIV, we of course are very interested to know whether all the strategies that we are applying, whether it's treatment or prevention, is making an impact. And what I've seen in terms of impact evaluation is really the role of large-scale population health surveys to be able to determine whether first our coverage is increasing, but also secondly whether we are making an impact in terms of reduction of HIV incidence. So one of the biggest investments I think is being made, particularly with PEPFAR, is the application of the population health impact assessments, the 10 years in the crisis, that have really demonstrated their utility in terms of where we're moving in terms of HIV. And in Kenya in particular, we've been able to see drastic decline in HIV incidence based on these methods that are being applied by the country. Another sort of design of tool that is applied commonly with implementation science is the use of social marketing, and been very successful, particularly in having a parallel strategy for market sort of demand creation for condoms. And recently also we've seen a lot of work around HIV self-testing, and it seems to be successful. We also know that a lot of well-designed plus randomized control trials and also economic evaluation trials and qualitative methods are informing policy. And just to mention some work from South Africa that has used costing and economic evaluation to demonstrate that differentiated service delivery for HIV is have better economic outcomes compared to the standard of care. But also there's a cluster randomized control trial from the Western Cape that has demonstrated that having people who are HIV infected come in to do their refills for their medication every 6 months is as good as a standard of care in terms of retention. And also qualitative studies do demonstrate that yes, health workers love this, or rather like this concept of differentiated service delivery, and that it decongest clinics, it reduces workload. So again, just to summarize that, yes, the impact evaluation, social marketing, and application of cluster randomized control trials, economic evaluation do have demonstrated impact and have actually made a difference. Because, for example, differentiated service delivery is now a recommendation from WHO. Now, moving forward into the future and looking at what priorities for implementation science would look like, and I'm happy, there's people from Gavi here and from the Global Fund, is that it would be desirable to really integrate implementation science methods, tools, and designs in the funding of public health programs. So whatever funding that Global Fund and Gavi provides to countries, it should by default include resources for impact evaluation or other implementation science methods that will then support programs. So coverage itself is not enough. And then using robust information systems that are digital and real time and funding them so that we can be able to, demonstrate impact over time, I think also is a very good investment towards implementation science. And then advocacy with the Ministry of Health to make sure that these implementation science skills are used across the board, capacity is increased, I think is something that is important. And of course, we need to continue to build partnerships around implementation science. So thank you very much. And I look forward to your questions later on.
Thank you, Peter, very much for your perspective. And I'll turn it over to you, Patty. And just to say to the attendees, we're going to sort of move through these panels, but feel free to put your questions in the chat as we go, but we'll have a moderated discussion at the end. Over to you, Patty.
Okay, well, thank you so much. I hope that you can hear me well. So I have been invited to talk about from the Ministry of Health perspective, but I need just to let you know that I work as a researcher, okay, and I am an academician, and it happened that I jumped into the Ministry of Health, okay, so although I will try to do my best, probably I will be a little tinted into also the implementation research side. So first of all, I think it is hard when you are working at the Ministry of Health to think about anything that has behind the name research, okay? So because there are myths that are behind that. And it's not only the minister, but all the people, several times, whatever is research is taken as a waste of time, okay? Unfortunately, that happens, which means that we really need to do a much better job on trying to position these strategies that can help us enhance the adoption of those measures that we know that work, okay? So that will be one of the first things. And being at the ministry, in general, the people that work at the ministry are having these constraints of time, pressure, politics, lack of funding, that we need to understand that exist. So to start with, I would like to mention some of the myths that I have seen when I was Minister of Health that relate to the issues of implementation science or implementation research. So one of the things that people will say when you said, like, let's try to work on this in a certain way, is that there is no time, okay? Because everything has to be done for the day before. And so I understand that that's true, but on the other hand, there is no time to fail. And when we are trying to do implementation science, what we are trying also is to measure and be sure that what we are doing works and will help, those strategies will help even for the future. So I think there is no time to fail, but there is time to do things in the right way. So a second myth that is very common is that it is more expensive than just doing implementation, okay? And so what I will say is that that failure is always more expensive, okay? And we never think about that. However, there is a limitation, and I'm not going to talk only about funding agencies, but also governmental funds, is that we have never thought about having included in our budgets issues that had to do on how to evaluate these things, or how to incorporate implementation science in the implementation that governments had to do. And maybe that is something that needs to be placed into the table and advocate and start talking about it. The third myth that I think it's important is that it cannot be done in reality, okay? And actually implementation science has to be done in reality. And there are examples of that I will give at the end. Although most of the people, for example, in my country, it's not that clear, especially at the level of the Ministry of Health, about what implementation science is or how to use it. Then Another thing that is said when you work at the Ministry of Health is there is no manpower to do this. And actually nobody says that it has to be done alone. I think that's one very important role of the academy, to try to work together so we could help in those issues. So the manpower exists. Maybe what we need to do is work in collaboration and also try to clarify why this is being done and how to do it without disrupting their regular activities, which is something that everybody is very concerned. And finally, this is the fifth myth, is that implementation science is not helpful. And there are lots of examples around the world on how helpful it is, because it can make things more effective and eventually more sustainable too. I just want to give 3 examples in Peru that show us, and we are trying to use as an to advocate to do implementation science. One was the implementation of the HPV vaccination. Okay, Peru was one of the places where there was this implementation study for HPV vaccination that actually taught us what were the facilitators, the barrier, help us to create instruments that eventually guided the introduction of HPV vaccination. And although not very much is written about what is going on here, we have been able to reach very high levels of vaccination of HPV in girls, probably from what we have learned from that experience. The second example is the implementation of rapid syphilis tests, which was also, Peru was part of a multi-country study. And actually we work very closely with the government and within the health centers and with the providers, doing this first understanding what was going on, what were the barriers again. So going, as Kenny was saying, through the stages to understand how could we make this better, how can this intervention could be adopted and sustained. And so now these rapid syphilis and double syphilis and HIV tests are policy and are implemented and are used widely and in a relatively very short time. And we keep evaluating and seeing how to improve these. So those are, and the third example is the implementation of the self-sampling HPV testing as a new strategy for screening for cervical cancer, which also started as implementation science, and we keep moving because we're trying to assure that not only we have the testing, but we can include innovation to assure that every HPV positive woman gets treatment. So again, from the point of view of the Ministry of Health, it's always difficult to try to introduce new things within the system. But I think we need to, number one, keep advocating for the importance of implementation science. I think if we should have used, or if we have used implementation science during this pandemic, not only in low middle income countries, all around the world, probably we would have better adoption of several measures that were important for the pandemic, okay? The second thing, I think it's important to think about the advantages and try to break all the myths that are around. And the third, we have to see how to incorporate these into the minds and into the budgets in order to be able to do it and to do better what the governments are supposed to do. That's it. Back to you, Russia.
Thank you both for your perspectives and insight. And over to you, Kenny.
Yeah, wonderful comments. Thank you. And next we're going to go to, and you know, Patty mentioned that she has lived in these both worlds of Ministry of Health and in the academic implementation research arena. And next we're going to go deeper into the academic implementation research arena. And we're going to start with Professor Binagwaho, who also has a unique perspective bridging Ministry of Health and large government agencies and the academic perspective. Professor Binagwaho was previously Minister of Health in Rwanda for many years, was Executive Secretary of the Rwanda's National AIDS Control Commission, as well as permanent Secretary of the Ministry of Health, and is now Vice Chancellor at University for Global Health Equity. So spans these two worlds, and I think that really brings a unique perspective. So over to you, Professor.
Thank you for giving me the floor, Kenneth, and very interesting to be in this panel. But what it shows me is that we still need a true and consensual definition of what implementation research and implementation science is. Because the more I listen to all my colleagues and partners, sometimes it's very difficult. And you are right. I have run the National Control Commission, the Permanent Secretariat Office, and the Ministry of Health Office, all these during 16 years. And I have to say that I was a fanatic of implementation science before implementation science as a name. And one name like that, but I realized that Rwanda was successful in what we were doing. It was because of the way we implement. But implement is not necessarily doing action, is the way, the strategy we use to implement evidence-based intervention. Okay, so now, since 5 years, we've done some studies with people who are here around, notably Patricia Garcia, on how countries have successfully decreased the rate of the under 5 mortality, meaning increase the rate of survival of under 5, and being exemplar contrary at what was expected. And there was, we did that for Peru with Pati, we did that in Nepal, in Bangladesh, in Rwanda, in Senegal, and in Ethiopia. 5 exemplar countries, and we tried to see what they did. And just to try to understand. So we all know that implementation science research allows countries to better identify first existing problem because it's data driven. Also identify the contextual factors that the country could leverage for better health outcome with the known or new or modified strategies. Also, when you identify the evidence-based intervention, you can modify them to suit the context you have. And so this implementation science approach allows also countries to adapt those strategies to other EBIs inside the country for other programs, or for the same EBI to other countries. But if it's simply adaptation, what we used to do 10 years ago, I mean, you remember, reproduce best practice without taking into account that the country has different contexts. And after that say, oh, we don't understand why it failed. So implementation science allows us to understand why strategy that have worked in implementing evidence-based intervention in a setting doesn't work in other settings because the contexts are different, the challenging and the facilitating contexts are different. It also informs how we can successfully scale up a process after a successful pilot phase. And so it reduces failure of programs implementation. It saves money. It increases the reach, the acceptability, the feasibility you have described in the beginning, Kenneth, and also the appropriateness of programs in the country or in other countries that try to use this, implement the same EBI. For instance, various studies carried out on implementation of integrated management for childhood illness in the year 90s informed the scaling up of the program in the same country and also in new countries. And studies highlight the importance of integrating data from this program into the health information management system, to providing in-depth training to healthcare professionals, how we do that. And what we found by analyzing Peru, Ethiopia, Senegal, Rwanda, Nepal, and Bangladesh, the strategies were almost similar. We did that study with Gates Venture and Bill and Melinda Gates Foundation. The strategy were almost, for success, were almost the same. And to prove that we are right, we should go and study that those strategies are not there in countries that didn't succeed. So to increase the use of implementation science, because for me, I was a successful PS minister, blah, 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 just because I analyze as we go, what are the EBIs proposed by the science? What are the strategies used by some countries? Why they were successful? What I have as context in my setting that can inspire me either to change the strategy to implement those EBI, either to just go for it without reflecting twice. So this is especially important in low and mid-income country because we have less money. But we need to increase the use of implementation science. We need first to equip academicians and healthcare professionals with the skills to conduct such a research. Most of the case, they are mixed method research. So, but it's not complicated. This is especially the case in low and middle-income countries, as the majority of training program and research projects are concentrated in high-income countries. In 2020, for example, a review of capacity building initiative in implementing science identified 41 initiatives, most of which were based in high-income countries. So one of the priority is to leverage existing new partnership to strengthen implementation science research capacity within government, within implementing partners, within academic institutions in low-income countries. Training in implementation science should be embedded within pre-service education and provide to health professionals in services, and also influence policies for that so that it's done on a regular basis, and the institution include the result in their policies, practice programs. So this will create a culture of continuous analysis of the work to ensure improvement in implementation outcome and evidence-based decision-making, but it can be done in health, but in all sectors is the same. So give this benefit, the University of Global Health Equity, where I'm Vice Chancellor, teach that across curricula, and we make it part of making the student permanent learners, permanent monitoring their job, their work, what they do, what they produce for permanent improvement. So that's what I can tell you. This is my experience. But my conclusion is we still need to come together to have a definition on that. And I'm not surprised, you know, remember the history of clinical trials. They start and they finally get a consensus after Nuremberg, then after the Second World War, when clinical trials were used against humanity. So the classification starts at that period. So we have a little time, but it's good that we all come together to reflect on what are we doing when we are doing implementation science research. I love it.
Fantastic. Thank you, Prof. So Malabika, if I can invite you for your comments.
Thank you very much. Actually, Professor Agnes gave a very comprehensive overview of implementation research. But I just want to start with that what COVID pandemic has taught us, that the health system needs to be resilient. That means the way health system responds, that panic response, then neglect. And the way we can make a resilient health system, like not to be panic and not to be neglect, through the implementation research, because implementation research gives the continuity of how the implementation strategies is going on. And it's very important to do it in the pre or early implementation stage. But there are some of the challenges. So I just want to share that the 2 studies recently have finished. One, on kangaroo mother care, which is one of the most easy, feasible, cost-effective intervention. It's not complicated. Mother just hold the baby. But when we did the implementation research, that's through UNICEF and the Ministry of Health, we found that even the fidelity is very poor. So the communicating with the mother and telling to mother, asking mother to hold the baby for a certain period of time, communicating with even the decision maker who are the mother-in-law or sisters who are there. So it's very important that it's not, we should not take it granted that the implementation, the evidence-based intervention is very simple and it can be implemented easily, even that there's struggle. The second one we have done, in introducing EPI tracker, the health assistant, the government health assistant to collect the digital data. And we found that, the older health assistant, they struggle. So what they do, they write everything on the paper manually and later enter into the EPI tracker, and which actually disrupts and the lot of mistake. So there's the one important point I want to make it is not the complex intervention. The simple intervention also requires that way the implementation fidelity, feasibility, acceptability. There are 3 major challenges. I would say that as a researcher, we do the complete the implemented research, and I also kind of lead implemented research capacity project funded by TDR. That to be implementation researcher, this researcher needs to understand intervention. They need to understand the context. So that's very important for us to be very sensible and sensitive and to be aware of the context, and also to how to communicate with the implementers, because implementation research questions should be formulated in collaboration with the implementer. Secondly, the for implementers also is very important to have the implementation research literacy, because mostly what we do, the intervention evaluation, and the evaluation means they think that they want to see whether it works or not. So there is not only reluctant, as Patty says, that the word, the research, but also that there's approach attitude that this is policing. They are coming here to identify what is our mistake, and implementation research is more into that, because we look detailed at how the implementation has been conducted. So it's very important to develop the capacity of the policymakers, but also the implementers. The third, I would say that the challenge for implemented research that when it comes to the post, later stage of the implementation, that before scale up, it's much easier to kind of adapt and formulate for scaling up. But the problem is the early implementation research is that there's not much resource allocated to change something. So resources have already been allocated to do the the intervention. So when we share the findings and say that this needs to be changed, and I think the first question the implementer said that, but we don't have any budget to adapt or change, because for scaling up is easy because the government or a large NGO or the international NGO, they have the fund. Say that, okay, now we'll scale up. So let's change or adapt the strategy or policy or the retraining or whatever. But early stage, there's not budget allocated. So this is also, I think, is very important for the policymakers and the funders and the implementers to keep in mind that if there's an implemented research is done, and then there are findings which need to be changed and it requires financial investment or other resource investment, need to be that flexible and open-minded to kind of give that money. Finally, I would like to say that, I think this is because implementation research is I think it's already 15 years old, and a lot of global discussion. But I do think that we should pursue to make implementation research included in the monitoring and evaluation framework. Because if we don't include it in the monitoring evaluation framework, implementation research needs to be in the pre-implementation from the very beginning. The way it can be successful in terms of the allocating the budget, the implementer literacy, and the researcher engagement, if we can bring them together and have a joint or combined monitoring, evaluation, and implementation research framework. Thank you.
Fantastic comments. Thank you, Malabika. And now I'm going to turn it over to you, Roman, for your thoughts.
Thank you, Kenny, and thank my two fellow panelists. Today's topic is really excellent, I think, because it deals with the interface of implementation science with three challenging and I would say uneasy keywords: scale up, population health, and low and middle income countries. Let me explain a little bit. For scaling up evidence-based practice, we are, according to a systematic review by Quinley and colleagues in BMJ Global Health, implementation research in low and middle income countries has mainly focused on evaluating whether or not implementation strategies works to implement some EBP. However, little of it addresses problems of scale up and sustainability. This lack of scale up studies is probably true for implementation science in low and middle income countries and also for high income countries as well. For population health, I think implementation science has traditionally focused on implementing evidence from clinical studies at the health facility level. Even though there is a rise in published papers on disease screening and other more public health-based approaches, the majority of the implementation science studies seems to be dealing with clinical challenges at the health facility level, rather than public health, health policies, and policy interventions at the regional or national health system level. So when scale up of evidence-based practice and population health are combined and placed in the context of low and middle income countries, the future priority for implementation science in global health setting seem evident. As health system and the policies in many of the low and middle income countries have been much less established than high income countries, implementation science in global health would need to take a more robust population health approach and deal with health systems and policy challenges. For example, we worked with Nepal quite a bit. As Nepal only started its social health insurance plan about 5 years ago, there is an urgent need to identify evidence-based practice in social health insurance, such as what is the best practice for payment mechanism, for benefit package designs, for premium compositions. And we also need an implementation strategy to implement those policy practice and scale up those best practices in health systems. And this new imperative is in stark contrast with the comfort zone of implementation science traditionally. We need to take bold steps in several fronts. Let me give 2 examples. One is, as researchers, we need to prioritize improving implementation science methods. Arguably, the defining characteristic of implementation science is its identification of evidence-based practice to address health challenges, and then develop and test implementation strategies to overcome the barriers to implementing the EBP. Methodologically, we need a different definition of EBP. Very often, it may not be possible to conduct RCTs for health system interventions in contrast to health facility-based clinical solutions. In that case, what level of evidence will be considered sufficient evidence to establish an evidence-based practice? That is the question. Meanwhile, once an evidence-based practice is identified, implementation science often uses theories, models, and a framework to guide the exploration of barriers and facilitators. However, most of those frameworks have been developed in high-income countries, and for facility-level problems, we need to improve, adapt, or even reimagine many of the frameworks so that they fit the needs of global health and health system-level applications. Furthermore, as a randomized RCTs are often not feasible for health system innovation, methodologies need to be refined so we can use many of the quasi-experimental designs to provide as high as possible evidence when an evidence-based practice is implemented in real-world settings. In addition to the methodological innovations required, I would also argue we also need to do more on studies illustrating the barriers and the facilitators for implementing health system best practices. Barriers and facilitators to EBPs in high-income countries have been relatively extensively studied, but low and middle-income countries' contexts would suggest very different barriers to be encountered. Also, implementation strategies for the health systems and population-based problems are likely to be substantially different from implementation strategies for clinical solutions at the facility level. However, studies in those areas has been very scarce. Lastly, as our fellow panelists have mentioned, capacity buildings in implementation science would be critical in low-income countries. I'm serving as a co-editor-in-chief of the Journal Implementation Science Communications. We have received many submissions, but few are from low and middle-income countries, and led by low and middle-income country authors. The quality of those submissions from LMICs are also tend to be low. So to conclude my points, I would like to recall one of my earlier experiences in tackling implementation science and health systems. That is almost 7 years ago. We worked with Professor Winnie Ip from Harvard to introduce global budgeting with pay for performance as a new payment mechanism for rural health insurance system in Guizhou province in China. We had great difficulties with implementation. Professor Ip at that time asked me how the field of implementation science can help. I said, sorry at that time. However, I hope I will say, yes, let's do it in the near future. Thank you.
Thank you, Professor Xu. Very delightful comments. I'm going to pass it back over to you, Rachel.
Thanks, and thanks for those comments. They were really insightful. We're going to move into the funders perspective panel. So we're going to start with some comments from Anita. Over to you, Anita.
Hi, good morning, good evening, and thank you very much for the invitation on this very important topic that we deal with a lot at the Gates Foundation. And implementation science just has a really important role in figuring out how to test interventions that have been shown to work in controlled settings, now in real world settings and getting you to scale. I have several favorite examples. Two of them were actually talked about already. HPV is a really good one where a lot of implementation science has been used to see how do you get high coverage in girls in populations that have not been the usual target of vaccination programs. And Patty Garcia talked about that. And my other favorite example is kangaroo mother care, where we know from clinical trial settings that kangaroo mother care, both in hospital and community settings, decreases child mortality. And now we are trying to figure out, and the NGF is funding quite a bit of this work. How do you implement kangaroo mother care for scale up through implementation science designs? Two other examples that people may not be familiar with are use of oral cholera vaccine. So oral cholera vaccine we've had now for over 10 years, but it was not really being used. We, from the foundation, started funding a lot of implementation science around outbreak control, when we would study how the vaccine in real world settings was performing. When do you use it? How soon after an outbreak is it effective? And that is a huge body of work has been built up around that, which is now resulting in demand far outstripping supply of vaccine, and of more than 100 billion doses of oral cholera vaccine have now been used, and we're trying to figure out how do we get more supply now to meet the demand from countries. And finally, another one that I have personally been involved as a researcher as well, and now have the sort of good fortune of being at the Gates Foundation and looking at this, is around outpatient treatment of sick newborns, where in many resource limited settings, it's not possible to hospitalize every infant with a rule out sepsis diagnosis like one does in high income settings. And so what can we learn from trying to implement practice of outpatient treatment for newborn rule out newborn sepsis, so clinically diagnosed sepsis, and what are the outcomes of doing this? I'll talk a little bit about challenges, and again, taking a funder's perspective here, the main challenges, I would say two main challenges is what comes up quite often. One is the contextual relevance issue that many people talked about, which is that context varies from setting to setting, may not be generalizable to different settings. And that can become a pretty huge funding challenge when every country, every context needs their own study and can then crowd out the either you're just working in a couple of countries or you're having to then make trade-offs between trying to do other things and funding primary intervention research. Another one, I think, which is more solvable and for the field to consider how to get there is the use of pragmatic designs or adaptive designs. Because if we have many examples from the foundation where we funded large implementation science studies of like 30, 40, $50 million that take 5 to 7 years to finish, and in the end, it's a negative study. And so not only is it a huge setback to the field where you now have wasted 5 to 7 years trying to see how something can be work in a real world environment. So instead of very rigid, highly controlled RCTs, how can the field move to pragmatic, adaptive study designs where we learn by doing? So it's iterative learning, and so in the end, at the end of your 5 years, at least you figured out how to make it work in that setting. Another priority I would highlight for the field would be really. This has become so obvious during the COVID pandemic, is behavior change communication. What behavior change communication strategies can work in different contexts, and just really advancing the sort of health communication field. And it's surprising how much lack of data there is for behavior change communication and what works in different contexts. I will stop there and happy to take questions from the audience.
Thank you, Anita. That was really useful and an interesting perspective. We're going to move over to John Reeder for his comments.
Thanks, Rachel. Well, we often hear about the valley of death in product R&D, and I come from a background in this, and only a small proportion of potential products make it through clinical trials to licensing. But we hear a lot less about the second valley of death, which is between the availability of products and interventions and scale up into routine use and impact. And of course, we need new products and solutions, and this is not a competition, but we also need to deliver existing solutions to scale and to deliver the impact that they promise. We've only got to look at the current situation with COVID vaccines, 75 times more coverage in high income versus low middle income countries. 40% of people with drug-resistant TB not enrolled in treatment. And right now in Africa, 10 million eligible children not having access to seasonal malaria chemo prevention. So this is not discovery research, this is delivery science. Half of WHO's listed neglected tropical diseases are now in middle income countries. So we should, in these contexts, be talking about neglected populations and not neglected diseases. And I think delivery science is really essential to tackle this inequity. We've got a lot of specific examples about how implementation research has provided evidence to remove roadblocks for healthcare. But what I want to focus on for a couple of minutes here is how we can make sure this research benefits everybody. And TGR is strongly committed to building capacity for the generation and use of implementation research. And really nice to hear from other panelists that this is one of the things that's really valued and needed. But while this still involves supporting the more academic research training we've heard of, we also have a really strong commitment to put these tools in the hands of implementers and not just in the hands of academics. We really need to destigmatize and democratize the research and to put it as a really practical tool directly in the hands of health providers. And I want to mention two initiatives we've been working on to try and push forward this particular agenda. The first of these is SORTIP, which is the Structured Operational Research Training Initiative. And this brings together implementers with research mentors over a one-year cycle of workshops taking these participants from looking at their own routine data and implementation problems through to developing and conducting research and communicating findings in a policy-friendly manner. We've now trained more than 1,000 implementers in almost 100 countries. And the real striking thing about it is because they're answering the real questions they encounter in their work, over 70% of this research has led to changes in practice and policy, much higher than you would expect if you were looking at just academic research that's been published. Furthermore, I mean, while none were trained as in epidemic response, interestingly, we did a quick survey and 70% have been able to redirect their new flexible skills to assisting in the COVID responses in their countries. So it's also showing the importance of basic research knowledge at an implementation level to make a responsive health system. The second example I just wanted to give is our involvement in recent years of bringing research into the service of community-based social innovations. And we are part of a social innovation and health initiative. And our role in this is not to be the innovators, but is actually to strengthen the capacity of those innovators to conduct basic research on their own programs and to understand what works, what doesn't, and what are the issues about scaling up. And again, having this information has allowed the transformation from local-based initiatives to real scale up, and examples such as the health centers by phone in Malawi started at a really small scale, testing whether actually when you hadn't got enough healthcare workers to go in the health centers, sitting them in one place with phones and connecting them to a mobile network, is that more effective than having people have to travel in distances to the zones? Yes, much more effective. It's now spreading out across Malawi. And using drug shops in Uganda to give advice on integrated management of child health. Again, implementation research as put in the hands of, done by the implementers, but put in the hand of the government, the information they need to scale this and realize this is a really good investment of health resources. So I'll end by just saying, I firmly believe that it's not just about growing implementation science and delivery science, but it's actually putting these tools into the hands of the implementers. And by doing this, I think we can make real progress towards universal health coverage and equity in health implementation. Thanks, Rachel. Back to you.
Thank you, John, for your comments. And I'm reflecting this collection of perspectives is really rich and important, I think, for the field. We're going to move to Lola Adedokun now for her perspectives. Over to you, Lola.
Thanks, Rachel, and thanks all for joining for this really interesting conversation. So I'll start first by just saying I spent the last 14 years working at the Doris Duke Charitable Foundation, leading our African Health Initiative. That initiative was launched in 2007. And the real vision was, or the hypothesis was, that by centering implementation research as a driver for informing and guiding primary healthcare systems strengthening would result potentially in measurable population health impact. So that relied on the fact that we had to, one, embed implementation science and funding for that, that was adaptable and flexible within a larger evaluation that was your traditional impact evaluation that, that participants agreed on what the measurable impact might be. The agreement was that the projects, they were working in Ghana, Mozambique, Rwanda, Tanzania, and Zambia, would assess whether or not their interventions that were defined by national government, not by the foundation, would result in reductions in either total fertility rates or under 5 mortality. An ambitious agenda, but they were given 5 to 7 years to implement nationally identified interventions to achieve that goal. I'll note that, when we talk about the work, I'd say after about 20 years of investment, about $100 million, we're now reflecting sort of on what that means for the field, what that means for the projects, and also what that means for national governments who invested their systems leaders, their time and energy to kind of guide this work. I'll say one thing about that is the legacy. And I want to note this for the audience and for our colleagues and partners. We've all invested heavily in individual implementation scientists who are on the ground doing the work, ready to lead in many other ways. So as funding partners and colleagues, what I think will be essential is that we call attention to who those scientists are that already exist, that are already prepared to carry through an implementation science agenda within country and at the global level. I want to give two examples of how implementation science has informed the scale up of evidence-based interventions. One is in Rwanda. So the government decided that the intervention they wanted to test out and trial was supporting nurses and providing more direct mentorship around them as they delivered services. What they realized 2 to 3 years into the project was that there was a real need to move the needle around neonatal mortality. So layered onto that was an 18-month implementation science research project focused on neonatal resuscitation and building that capacity and ensuring that nurses were able to deliver that service within community. After that 18-month trial, they noted a measurable, substantial reduction in neonatal mortality within the 3 districts it was tested in. That's 18 months, and that was a sub-implementation research study that totaled maybe $30,000. That just goes to show that these are the kinds of investments that go a long way. And because of that, that was scaled. This neonatal resuscitation training program was scaled nationally. I'll also note another example in Ghana. Many of you may have heard of the CHIPS program. It's a community-based intervention that was brought over, adapted from Tanzania to the Ghana context. And after maybe 25 years of implementation, there hadn't been any reflection on how to change or adapt that package for a new day. So our funding went to adapting that package under the leadership of the government. And now that package has been adapted and scaled nationally and has also shown reductions. More importantly, it's shown improvements in health system strength and service delivery. And it's now nationally scaled. So I name that also because we have to remember that we are leaning and relying on national government really to test and trial. And it requires a direct investment, not only in the research, but also in the leadership and the trialing at many levels of the system, not simply district, but also regional, provincial, and national, to sort of creating that culture. And I just want to kind of transition about priorities. We're, as others have alluded to, at a very fascinating moment where the winds of philanthropy, I'll say, and governments are calling for power shifting, are calling for investment in local research institutions and local leadership, and are calling for decolonization. These investments in training local researchers and empowering governments to determine their own research questions, to be flexible, to adapt, to be able to articulate in a place where delivery challenges exist, that they're having challenges, and then having the resources to test and trial innovations to overcome these challenges. This is the moment, and this is one of those mechanisms. I'll also note that what one must think about when we talk about scale up and building and expanding this movement around implementation science is that we have to fund the ecosystem. We have to fund the researchers in the pipeline, which those have noted. We have to also fund the larger impact evaluations and embed science into that. We have to directly fund governments and empower them to design questions, to really be socialized around the value of implementation science. And we have to give the visibility and the connective tissue between researchers, national leaders, and global advocates, as well as our global funders. So that's a lot of investment. But as partners, we've heard other colleagues talk about this, this calls for coordination, this calls for collaboration, and this calls for transparency in what we know is working, and honesty about how we will go about supporting an activated, vibrant community of scientists who are in place to really accelerate the agenda around population health, growth, development, and improvement. So I'll stop there.
Thank you, Lola, for your reflections. They're quite wise and appreciate them very much in the mix. We're going to move over to David Chambers. Over to you, David.
Thank you. And I want to extend that thank you to everyone who's listening in and the wonderful comments of the panelists that you've already heard from. I think I'm last right before the question and answer, so I'm going to try and be as brief as I can. But the thank you extends that the reason why I've been at NIH for the last 20 years is actually because I was attending a meeting and participating in this discussion about how we think about mental health in the context of health packages within the low and middle income countries back in 1999 and 2000. And it was that direct line that led me to connect with folks at NIH who are thinking about how do we integrate research into practice, which then became this notion of dissemination and implementation research, and then became the implementation science, wonderful content that we've been talking about. And so thanks to all of you who continue to teach me. Thanks for all that I've learned so far on this call. It's just wonderful to be back to bask in your glow once again. So the kinds of things that I learned even then and the things that we've been trying to work on at NIH over these last 20 plus years resonate very much with what we've already heard, that context matters so much, that integration of various interventions of tools of all the P's that Kenny started out with into systems of care, taking advantage of the opportunities, taking advantage of the local expertise, the experience, because evidence-based medicine, as it was originally defined, was not about evidence overcoming all things, but it was the natural integration of evidence along with the preferences of populations and systems and the expertise that has been borne out over decades, over generations of experience. And so that's what sort of anchors me, both in thinking about implementation and then more specifically thinking about how we scale up interventions. That implementation, of course, is a process. We've talked about the recognition of various barriers and facilitators that may vary among different contexts, but are incredibly important toward crafting those implementation strategies that Kenny had talked about to give us a chance of being able to try and optimize health and healthcare for as many people as possible. So the mission of NIH, where I've been for now, again, 21 plus years, is turning discovery into health. And so those of us who focus on implementation science at the NIH take that as our mission, as our reason for being, because we can't transform these wonderful discoveries into health without understanding exactly what you've all talked about, this interplay between policy and practice, between populations and the evidence and the different interventions that we may be able to benefit from. And so I thank so many of my colleagues at the NIH, whether it's Rachel and others at Fogarty, whether it's our own at the National Cancer Institute Center for Global Health, folks at NICHD, at NIMH, at NHLBI, partnerships between the Global Alliance for Chronic Disease and our researchers and our agency toward trying to improve practice worldwide, because those have been the difference makers, really, as I see it, of moving us to have better and better conversations about how we can indeed do better and better. So NIH does have funding opportunities. We have conferences, we have workshops, we have sort of open access trainings, all toward the service of building capacity, not for individual investigators, but really building capacity of teams, right? It's a team sport. And so I think everybody before me has emphasized that this isn't anything that one person can overcome all hurdles, but it's really about how we work together to do that. Just quickly, the kinds of priorities that I think are really great opportunities for moving forward are things that you've already heard. So how do we do a much better job of understanding adaptation of our interventions, not assuming that we adapt within a trial and we assume we have the answers for implementation, but how we think about adaptation in the presence of implementation and in the presence of scale-up. Sustainability, that we're not content with just being able to do something well, hopefully on day one, but that we're actually bringing interventions, bringing programs and practices that can be sustained and ideally can improve over time. That we don't think about implementation in a vacuum, but we're aware of what practices are pre-existing. And so in some cases, there may be a negotiated process of abandoning or de-implementing some of those practices. But in any case, it's understanding the local context and local practices and trying to leverage them as much as possible. So bundling of interventions is one last thing I'll say, that too often we say, have we got the magic intervention that will cure all problems? And instead of saying, no, it's probably about bundling, the kind of thing that Roman was talking about in terms of evidence-based systems of care, or John was talking about in terms of delivery science, this broader, how do we understand optimal delivery of our interventions? So with the last thing towards saying, I would underscore our need to continue to build capacity to improve our methods and measures. I just, again, want to say thank you and would love to see what questions and what time we have for discussion.
Thank you, David, and thanks to all four of you for your rich reflections. And I guess I would say to all of the panelists, this is an incredible source of wisdom. I'm going to turn it over to Kenny, who's going to moderate the moderated discussion. Over to you, Kenny.
Great. Well, thank you, Rachel. We've got about 10 to 15 minutes left in this panel. We want to take questions from the audience. So if you have the ability to put that into the question and answer interface on Zoom, or maybe raise your hand, come off mute, and you can ask your question. And I invite all the panelists to engage their cameras, please.
I had a question, Kenny.
Please, Rachel.
Sure. I was interested in sort of, this is to all of you really, from your different perspectives, but I'm interested in your reflections on sustainability and planning for sustainability in the context of implementation science. And I guess just to make it more complicated, both in the context of the implementation research, but also when we think about capacity and building capacity in LMICs. So anyone, feel free to comment.
Well, maybe Rachel, I could jump in and probably just focus on training and sustainability of training. I think just to emphasize, I think the point that John made earlier, or either John or about really trying to cascade implementation science capacity to the lowest levels possible. And I think that is something that we should emphasize and that we should democratize, as it were, the implementation science so that it's applicable, across agencies, across, I would say probably cadres of healthcare workers, so that, sort of we integrate the DNA of implementation science, basically to everyone who is involved in this field. I think that's one way of ensuring sustainability.
Great, thanks, Peter. Patty, your hand is up.
I want to second what Peter has said, okay? I think this issue or this idea of cascade, or if you want a pyramid, right? We need to create a basis in which, in general, people should understand what implementation science is to break all those myths that I talked about. So that's the first thing. And when I said everybody, I'm talking about health professionals in general. And I agree when Agnes was saying like it should be embedded, okay, in some way in the curriculum of health professionals. So at least to know what it is and have some respect and understand what are the advantages and the goods that can come from it, okay? And then we can have maybe short courses for specific ones, and then think about maybe, I don't know, careers, masters, and those that are going to be dedicated on creating the theories and the new frameworks, okay? So we need that a spectrum of understanding and creating more knowledge so this could be sustainable. I think that's one of the bases, because once people understand what it is, how helpful it could be and how this can help, then we can assure, I hope that we can assure that there is not only interest, but there is also funding that will come. And I mean, I think it's great that we have the funders here, but I think governments should also realize that this is something that is important and should put also lines in their budgets. It's incredible when you see within the governments, and depending where you go, there are lines that you are not allowed to have within the government, okay? Maintenance, this is something that I have been fighting for, okay, in my own country. So maintenance, which is critical. So this type of research or evaluation, some people still think that that's wasteful, and it isn't. So how can we fight that and assure sustainability? We need to create even the basis of knowledge and understanding of why this is being done. Thank you.
Can I jump in?
Please.
So I think that I don't have a problem for sustainability because I did it, you know, and it can, you need, as Patty say, to negotiate with your parliament to put that in your budget, because the law of budget is not done by the Minister of Finance, even by the Minister of Finance a bit, but it's voted by the parliament. So if we go and say, I remember, we need to do this study to do that, you have the answer, enough studies, say, you know, and this is coming from, not because people are against academia or what, it's just because the money is there, the envelope cannot be bigger, and they want people to stop dying. They don't understand that we will help them more if we have this approach of implementation science. Second, I am against the donors, you know, they don't fund implementation science study. Even NIH, you can say whatever you want. It was a nightmare to have money to do that. And also when we receive the money, 60% have to remain in the US. So we have a problem among funders as well. I don't say that I was so surprised to gain the first grant in implementation science with Bill and Melinda Gates Foundation for understanding why people, young under 5 were not dying. And this is key because implementation science allows us to save millions without new knowledge, millions, by applying all the evidence-based intervention that we already know. And it's far more productive than new trial to help countries to implement what already work according to their context, of course, not in a customized way, and with their input and ownership. So sustainability is there. It's just about us. It's just us about talking about this. And it's just the donors to understand that is the wise way to put the money.
Thank you, Prof. Malabika, I saw your hand was up earlier. Do you still?
No, because Professor Agnes has said like what I wanted to share, but yes, thank you.
Okay, thank you. Well, there's a question in the chat around career pathways for implementation science. Does anybody want to comment on the career pathway for implementation science? We have here academia, we have government perspectives and funders' perspectives. What does it look like to work in the field of implementation science? Is it a generalist position? Is it a sub-specialty position, such as within HIV and implementation science? Any thoughts?
Let me answer that, because TDR is like, you know, John is here. TDR actually, like this is the second phase that granted the fund to 7 universities globally in the South to train the master's student and PhD student on implementation science. So there is a career path definitely that specifically I know the TDR is investing a lot on infectious disease. But there are also universities who are starting masters in implementation science. There are a lot of PhD in implementation science. But one of the major challenge, particularly for master's student, not for PhD, that after doing the master's, finding a job where they can do implementation research is still limited. Because exactly what the problems that Agnes has shared. So I think we need to kind of sensitize the policymakers, the implementers, and also funders that to give the opportunity to the young professional who are trained in implementation research and working in a organization or academic or Ministry of Health to get engaged, to engage in implementation science. Yeah.
Great. Do other panelists want to comment?
If you allowed me.
Sorry, go ahead, Patty, you can go ahead.
Yeah, thank you. It's so interesting. I mean, I don't know if other countries do the same, but I think in the US, everybody thinks about the career pathway, right? So where am I going to be working with and thinking about the future? Sometimes in our countries, we don't have that luxury, okay? We do whatever is there. So I rather think about, again, what we were talking about, the cascades, okay? And think that there are opportunities, the opportunities exist there, and we need all kind of levels of training in implementation science to try to fill all the gaps that we have, from the point of having people that will allow to do it and people that will understand, like the people from the parliament, so they will be facilitators in order to get the funds that are needed, to the people that will be really doing the work or collaborating from the health sector and the academia, working in collaborative groups, to the people that will continue creating all the theories and frameworks, etc. I don't think there is a clear space at this point, okay? But there is a lot of opportunities, and if we create the enable environment to keep growing this area of work, which is very much needed. And that my wish is that for the next pandemic, okay, we could be prepared to involve more implementation science to do things better, because we know how bad we have gone.
Thank you, Patty. Final two comments. I'm going to just do a few words of close up. This session ends in less than 3 minutes. So Roman and then Professor Binagwaho.
Yeah, for this question about career pathway, I think this is related to how we see implementation science. I very often get a question when I make presentations on implementation science in China, is they ask whether implementation science is a discipline, a field, or just a method. We have similar questions when we are developing global health initially. Same question, is it a discipline, a field, or simply a method? I think if you want to pursue academic career, your society and your contacts and how they define implementation science will matter. Because if it is a discipline, then you have a department, you have dedicated people working for that. If it is a field, then probably people have their primary appointment, then working with some interface linking to that. For the development of global health, I think it's moving in both ways. There are a narrow group of people who specialized in global health departments, but there are so many more who are probably cancer specialists and NCD specialists, but they have an interest in global health. I would say implementation science are probably moving in the same direction. Like in University of Washington, we already have a PhD program in implementation science, but many other people will be in other disciplines, but take on some flavor of implementation science and moving in that direction.
Thank you, Roman. Very quickly, Agnes.
I just want to build on what Roman said. We need that at all levels. We need people who do PhD, I just create the Department of Implementation Science at UGHE officially. We were doing it, but because it's needed. But all our students have to be trained in implementation science, because it will make your pathway stronger. You will be better in what you do. You will produce better for the country. We need everything, and there is no limit. And pathway, tell me you start a career and finish in it. Nobody. So just go where the wind push you, be the best, and for this you need implementation science.
Thank you, and thank you all. This has been a great conversation, a great panel. We're going to have to close now for the next sessions of the conference. I just want to say this multidisciplinary perspective is what implementation science is all about, and it's going to be a group effort to try and close this no-do gap and ensure that we're using and maximizing evidence-based interventions for the benefit of populations. Thanks again.
Thank you. It was great to see all of you. Bye-bye.